Hello students, welcome to this session. I am Dr. Rajeshri Mutha, Department of Microbiology.
Hello students, welcome to this session. Let's study enterobacteriaceae. So in that we will see E. coli, Klebsiella, Proteus, Yersinia, Salmonella and Shigella. So enterobacteriaceae family characters are gram-negative bacilli, aerobes and facultative anaerobes, non-fastidious. Ferment glucose to produce acid with or without gas. Reduce nitrate to nitrite. Catalase positive, oxidase negative. Motile with peritrichous flagella or non-motile. Mostly commensals in human intestine, coliform bacilli. So classification, lactose fermenters, LF, all are coliform bacilli, ferment lactose producing acid. On Mekongki agar produce pink color colonies. And example, Escherichia, Klebsiella, Citrobacter. Non-lactose fermenters do not ferment lactose, produce pale or colorless colonies on Mekongki agar. Salmonella, Shigella, Proteus, Morganella, Providentia, Yersinia. Let's study E. coli, Escherichia coli. So virulence factors, most common aerobe harbored in gut of humans and animals. Surface antigen, somatic O, most important virulence factor, endotoxic activity, protects from phagocytosis and bactericidal effect of complement. Second, flagellar antigen, capsular antigen K and fimbrial antigen. Toxins, hemolysin, virulent strains of E. coli, especially pyelonephritis strain. Cytotoxic necrotizing factor 1 and secreted autotransporter toxin. Cytotoxic to bladder and kidney cells. Enterotoxin produced by diarrhenic strains of E. coli, heat labile toxin, heat stable toxin, and virocytotoxin. Toxins LT and ST, heat labile and heat stable. So heat labile toxin produced by enterotoxigenic E. coli, plasmid podate, resembles cholera toxin. Mechanism of action, subunit B binds to GM1 ganglioside receptors on intestinal epithelium. A fragment is internalized and cleaved into A1A2 peptides. Fragment A2 help in tethering A and B subunits together. Fragment A1, active fragment, causes ADP ribosylation of G protein, upregulates activity of adenylate cyclase, intracellular accumulation of CAMP, increase outflow of water and electrolytes into gut lumen, diarrhea. Detection of LT, toxin detection, latex agglutination, ELISA. Molecular methods, PCR detecting gene, coding for LT. Heat stable toxin produced by enterotoxigenic E. coli, plasmid coded, ST of two types, ST1, ST2. ST1 mechanism binds to guanylate cyclase C, increased production of cGMP, and fluid accumulation in gut lumen, diarrhea. ST2 causes fluid accumulation by unknown mechanism. Detection of ST same as LT. Clinical manifestations, one of most common pathogen encountered clinically, urinary tract infection, uropathogenic E. coli. Diarrhea, 6 types of diarrhogenic E. coli, enteropathogenic EPEC, enterotoxigenic E. coli, ETEC, enteroinvasive EIEC, enterohemorrhagic EHEC, enteroaggregative EAEC, diffusely adherent E. coli, DAEC. Other infections, abdominal infections, commonest cause of primary and secondary bacterial peritonitis, visceral abscesses, hepatic abscess, pneumonia in hospitalized patient, VAB, meningitis, especially neonatal, wound and soft tissue infection, cellulitis and infection of wounds, osteomyelitis, endovascular infection, and bacteremia. Laboratory diagnosis, specimen collected, pus, exudate and wound in cellulitis and pyogenic wound, urine in UTI, stool in diarrhea, CSF meningitis, peritoneal exudate peritonitis, sputum pneumonia, tracheal aspirate, ventilator associated pneumonia, blood bacteremia. Direct microscopic examination stained by gram staining. Smear shows gram-negative bacilli. Culture aerobe and facultative anaerobe, non-fastidious. Blood agar colonies are big, circular, gray, moist, occasionally beta hemolytic. Mekongki agar pink due to lactose fermentation. Liquid medium, uniform turbidity. Culture smear and motility, gram-negative bacilli. Hanging drop method, motile bacilli. Biochemical test, catalase positive, oxidase negative. IQ test, Indole positive, citrate urease negative, triple sugar ion shows A by A, yellow, yellow, gas present, H2S absent. Methyl red positive, VP negative. To summarize, E. coli morphology gram-negative rods, single peritracheate flagella, motile, classification enteropathogenic, enterotoxigenic, enteroinvasive, enterohemorrhagic, enteroaggregative, diffusely adherent E. coli. Pathogenicity, urinary tract infection, diarrhea, pyogenic infection, wound infection, peritonitis, meningitis, septicemia. Laboratory diagnosis, specimen collection according to the manifestation like urine, pus, stool, sputum, etc. Direct microscopy gram-negative bacilli on gram staining, culture characters, blood agar, beta hemolytic gray circular colonies, Mekongki agar pink due to lactose fermentation, moist colonies, biochemical reaction, indole positive, MR positive, PP citrate urease negative, motile TSI ABA A with gas and no H2S. Let's study Klebsiella. Klebsiella found as commensal in human intestine and as saprophytes in soil. Genus Klebsiella has two species, Klebsiella pneumoniae and Klebsiella oxytoca. Lactose fermenters, non-motile and capsulated. Pathogenesis Klebsiella pneumoniae, subspecies pneumoniae. The most pathogenic, the severe lobar pneumonia, destructive with production of thick mucoid brick red sputum. Second, urinary tract infection, meningitis in neonates, septicemia, and pyogenic infections such as abscesses and wound infection. Colonize the oropharynx of hospitalized patients. Common cause of nosocomial infection. Most hospital strains are multi-drug resistant. Klebsiella ozini subspecies, tropic rhinitis ozina, foul-smelling nasal discharge, biochemically inactive. Klebsiella pneumoniae subspecies rhinoscleroma, chronic granulomatous hypertrophy of the nose, Southern Europe, India and Central America, biochemically inactive. Laboratory diagnosis, specimen sputum, endotracheal aspirate, blood exudate, direct microscopy, gram staining, short, plumb, straight capsulated gram-negative rods, culture Mekongki agar, large dome-shaped mucoid tutu capsules, sticky pink color lactose fermenting colonies, biochemical indole test negative, citrate urease positive, triple sugar ion A by A, that is yellow, yellow, gas present, H2S absent, methyl red negative, VP positive. Klebsiella oxytoca is biochemically similar to pneumonia but differs from by indole positive. And then fifth is the AST, antibiotic sensitivity test. To summarize, Klebsiella, morphology gram-negative bacilli non-motile. Classification Klebsiella pneumoniae and oxytoca. Klebsiella pneumoniae of three species, that is Klebsiella pneumoniae, ozini and rhinoscleromatis. Pathogenicity of Klebsiella pneumoniae, pneumonia, nosocomial infection, ventilated associated pneumonia, urinary tract infection, diarrhea, pyrogenic infection, septicemia, meningitis. Lab diagnosis, specimen sputum, endotracheal aspirate, gram staining, short, plumb, straight capsulated gram-negative rod. Culture Mekongki agar, large dome-shaped mucoid, pink color because of the lactose fermentation colonies. Biochemical test, indole MR negative, VP citrate urease positive, TSI A by A, AST. Hello students, let's study Salmonella. So clinical classification, oldest is the friendly one. So first is typhoidal salmonella, which includes serotypes like S. typhi and S. paratyphi, restricted to human host, which causes enteric fever, that is typhoid and paratyphoid fever. Second is the non-typhoidal salmonella, all NTS. They colonize intestine of animals and also infect humans, causes gastroenteritis and septicemia. Antigenic structure, three important antigens on their cell wall, somatic antigen O, flagellar antigen H, and surface envelope antigen VI found in some species. So VI antigen, surface polysaccharide envelope or capsular antigen covering the O antigen, named with the belief that VI antigen is related to virulence, expressed in only few serotypes, S. typhi, S. paratyphi, S. dublin, and some strains of Citrobacter frundi, renders the bacilli inagglutinable with O antiserum, agglutinable after boiling or heating at 100 degrees Celsius for 1 hour, which removes VI antigen. VI antigen is poorly immunogenic and antibody titers are low, not helpful in diagnosis of cases. Complete absence of VI antibody, poor prognosis. Disappears early in convalescence. If persists, then it is called carrier state. Fast typing or F's typing using VI specific bacteriophages. VI antigens used for vaccination. The features of O and H antigen. O antigen, somatic antigen. H is flagellar antigen made up of proteins flagellin. O is part of cell wall lipopolysaccharide. H confers motility to the bacteria. O is heat stable, alcohol stable. H heat labile, alcohol labile. O formaldehyde labile. H formaldehyde stable. O in Vidal test, O antigen of S typhi is used. In Vidal, H antigen of S typhi, S paratyphi, and A and B are used. O antigen is less immunogenic, H is more immunogenic. O antibody appears early, disappears early, indicates recent infection. H antibody appears late, disappears late, indicates convalescent stage. When O antigen reacts with O antibody, forms compact granular chalky clumps. Agglutination takes place slowly, optimum temperature 55 degrees Celsius. When H antigen reacts with H antibody, forms large, loose, fluffy clumps. Agglutination takes place rapidly, optimum temperature 37. Serogrouping is based on O antigen. Serogroups are differentiated into serotypes based on H groups, H antigen. O antigen, also called Boyne antigen, extracted from bacterial cell by treatment with trichloroacetic acid, first shown by Bovin. Flagellar antigens exist in two alternative phases, phase 1 and phase 2. Most of them are biphasic except monophasic, S typhi. Typhoidal salmonella, S. typhi, S. paratyphi, ABC, which cause enteric fever. Pathogenesis, transmission fecal-oral, infective dose minimum 10 raised to 3 to 10 raised to 6 bacilli. Risk factors which promote transmission, conditions that decrease stomach acidity, less than 1 year age, antacid ingestion, achlorohydria, or prior Helicobacter pylori infection. Intestinal integrity, inflammatory bowel disease, prior GI surgery, or suppression of the intestinal flora by antibiotics. Entry through epithelial cells, M cells lining the intestine. Bacteria-mediated endocytosis mediated by type 3 secretion system. Entry into macrophages, salmonella containing vacuoles cross epithelial layer to reach submucosa, phagocytosed by macrophages. Survival inside macrophages induce certain alterations on its surface, which causes insusceptible to lysosomal enzymes. Primary bacteremia from inside macrophages spread via lymphatics to enter the bloodstream. Transient primary bacteremia spread disseminate throughout the reticuloendothelial tissues, liver, spleens, lymph nodes, and bone marrow. Further multiplication. Secondary bacteremia occurs from the seeded organs, and which causes the clinical manifestations. Clinical manifestations, incubation period 10 to 14 days, fever, left step ladder pattern type of remnant fever, other symptoms headache, chills, cough, sweating, myalgia, and arthralgia. Rash called rose spots, faint salmon colored, blanching, maculopapular rash, trunk and chest 30%. Early intestinal manifestations, abdominal pain, nausea, vomiting, anorexia. Important signs, hepatosplenomegaly, epistaxis, and relative bradycardia. Complications, GI bleeding, intestinal perforation in third and fourth week of illness. Neurologic manifestations, meningitis, cerebellar ataxia, neuropsychiatric symptoms, muttering, delirium or coma and vigil, paranoid psychosis, hysteria, delirium, and aggressive behavior. Lab diagnosis of enteric fever. So first is the sample collection. So according to duration of illness, the specimen and test done. So first week, culture of blood, bone marrow aspirate, duodenal aspirate. Second and third week, serum for antibody detection by Vidal test for antigen detection. And stool and urine culture. Fourth week, stool and urine culture. Carrier, stool and urine culture. Serum for detection of antibodies to VI antigen. Sewage culture, indirect way. Culture. So first blood culture, sensitivity 90% in the first week. Clot culture, blood is centrifuged, serum for Vidal test and clot for culture. Culture medium, conventional brain heart infusion broth, Castaneda's biphasic medium, that is by BHI agar slope and BHI broth. Automated blood culture systems like Bactec and Bacti alert. Sodium polyethanol sulfonate, SPS, used as an anticoagulant, counteracts bactericidal action of the blood. Incubation 37 degrees Celsius up to 1 week. Repeat subculture, monophasic BHI medium, periodical subculture onto blood agar and Mekongki agar. Biphasic medium, BHI is preferred over monophasic subcultures in the same bottle. Automated blood culture system, monitor growth continuously and positive growth flagged, then subculture done on blood agar and Mekongki agar. Enrichment broth, selenite F broth, tetrathionate broth, and gram-negative broth are used. Selective media, low selective Mekongki agar, which gives the colorless colonies. Highly selective media, DCA, deoxycholate citrate agar, pale colonies with black center. XLD agar, xylose lysine deoxycholate, red colonies with black center. SS agar, Shigella salmonella agar, colorless with black center. Hecton enteric agar, blue-green colonies with black center. Wilson Blair brilliant green bismuth sulfite medium, jet black colored colonies with metallic sheen due to production of H2S. Identification, S. typhi, culture smear and motility, gram-negative, non-sporing, non-capsulated, motile with peritracheate flagella. Biochemical identification, catalase positive, oxidase indole negative, MR positive, citrate urease negative. TSI, K by A, alkaline by acid, gas absent, H2S, S. typhi, spake of H2S. In paratyphi A, citrate negative, H2S absent, gas present. In paratyphy B, citrate positive, abundant H2S and gas present. Slide agglutination test. S. typhi agglutinates with O9 antisera. S. paratyphy A with O2 antisera. S. paratyphy B with O4 antisera. Masking effect of VI antigen tested with VI antisera. Boiled for 60 minutes at 100 degrees Celsius, testing with O antisera. Demonstration of serum antibodies in second week. Vidal test. Principal tube agglutination test. O and H antibodies against S. typhi and paratyphi AB are detected. Antigens used for, that is antigen of S. typhi TO, H antigen of S. typhi TH, H antigen of S. paratyphi A AH, and H antigen of S. paratyphi B BH. Procedure. Patient serum is serially diluted in normal saline in test tubes from 1 to 10, 1 in 640 dilution. 4 such sets are made. To each set of diluted sera, respective 4 antigens, that is TO, TH, AH, BH, are added. Control tubes containing antigen and normal saline should be kept to check for auto agglutination. Test tubes are incubated in water bath at 37 degrees overnight. Result: O agglutination, compact granular chalky clumps, disc-like pattern with clear supernatant fluid. H agglutination, loose fluffy cotton leaf clumps with clear supernatant fluid. No agglutination, button formation, and supernatant fluid remains hazy. Titer, highest dilution of sera at which agglutination occurs. Significant titer in India, H agglutinin more than 200, O agglutinin titer more than 100. Low titer should be ignored and considered as baseline titer in endemic area. O antibodies are serotypes, non-specific. H antibodies are the specific. Interpretation of Vidal test, rise of TO and TH antibody, enteric fever, S. typhi. Rise of TO and AH antibody, enteric fever due to paratyphi A. Rise of TO and VH antibody, enteric fever due to S. paratyphi B. Rise of only TO antibody, recent infection. Rise of only TH antibody, convalescent or anamnestic response. Rise of all TH, BH antibody, post-TAP vaccination. False positive Vidal test may occur in anamnestic response, transient rise of titer due to unrelated infection like malaria, dengue in persons who have had prior enteric fever. Antigen suspension are not free from febrile. Persons with inapparent infection, person with prior immunization with TAP vaccine. False four-fold rise in antigen titer demonstrated by testing paired sera at 1 week interval is more meaningful. False negative, early stage first week of illness, late stage after 4 weeks. Carriers, patients on antibiotics, prozone phenomenon, antibody excess. This can be obviated by serial dilution of sera. O agglutinins appear early and disappear early and indicate recent infection. H agglutinin appear late and disappear late, and they indicate convalescent infection. Other antibody detection test, TIFI.OMP, outer membrane protein antigen is used, detect both IgM and IgG antibodies. IgM dipstick test and ELISA detects anti-LPS IgM antibodies. Dot blot assay, flagellar antigen is used and detect only IgG antibodies. Demonstration of Salmonella antigen in blood and urine by ELISA. Molecular methods, PCR, detect and differentiate typhoidal salmonella, flagellin gene, and other genes. Other non-specific methods, WBC count, neutropenia with leukocytosis, liver function test deranged, and the muscle enzyme level moderately elevated. Typhoid carriers, types fecal carrier, multiply in gallbladder and excreted in feces, more common. Urinary carriers multiply in kidneys and excreted in urine. According to duration of shedding, convalescent carrier 3 weeks to 3 months, temporary carrier 3 months to 1 year, and chronic carrier more than 1 year. Chronic carriers 1 to 4% of infected people, more common in women, infants, and old age. Biliary tract abnormalities which lead to increased fecal excretion. Abnormalities of urinary tract and associated cystosoma hematobium infection of bladder leads to increased urinary excretion. Food handlers or cooks who become chronic carriers, dangerous. Example, Mary Mellon, typhoid Mary, more than 1300 cases are infected from her. Lab diagnosis of carriers, culture, stool and bile culture detects fecal carrier and urine culture detects urinary carriers. Detection of VI antibodies. Tube agglutination test using VI is TIFI suspension carrying VI antigen but Nagar strain. Titer of 1 to 10 is also considered significant. Isolation of salmonella from sewage to trace the carriers in the communities. Sewer swab technique and filtration, that is indirect way of the diagnosis. Control of carriers, early detection of carriers by stool urine culture or by detection of VI antibodies, effective treatment of carrier by ampicillin or amoxicillin 4 to 6 gram per day plus probenecid 2 gram per day for 6 weeks, surgery, cholecystectomy plus ampicillin. Prophylaxis, control of reservoir, control of cases, early diagnosis and prompt effective treatment, disinfection of stool or urine soiled clothes with 5% cresol, 2% chlorine or by steam sterilizer. Follow-up examination of stool and urine culture to detect carrier, twice at 3 to 4 months and at 12 months. Sanitation measures, protection and purification of drinking water supplies, hand washing and improvement of basic sanitation, promotion of food hygiene and health education. Vaccine provides short-time protection. Indications, travelers going to endemic areas, those attending melas and yatras, household contacts, and people at increased risk, school children. First, parenteral VI polysaccharide vaccine. It is capsular polysaccharide derived from S. typhi strain TY2. Single dose intramuscular or subcutaneous, protection for 2 years, booster every 2 years, and age more than 2 years. VIREPA, VI antigen is conjugated with recombinant Pseudomonas aeruginosa exotoxin A, can be given to less than 2-year children. Typhoral, oral live attenuated S. typhi TY2 1A vaccine. Stable live attenuated mutant of S. typhi strain TY2 1A. Gal E mutant, so it lacks the enzyme UDP galactose 4 epimerase. Multiplies for some time, initiates immune response and self-destruction after 4 to 5 division. Indicated only after 6 years of age. Enteric-coated capsules before food on alternate days, that is 1357 with booster 5 after every 5 years. Protect immunity starts after 7 days and lasts up to 4 years. Salmonella, morphology, gram-negative rods, motility positive, swarming motility by peritracheate flagella. Classification, Salmonella typhi, paratyphi A, paratyphi B, paratyphi C. Pathogenicity, enteric fever, typhoid fever with a Salmonella typhi, paratyphoid fever, Salmonella paratyphi ABC. Septicemia, gastroenteritis or food poisoning. Fever, step ladder pattern, remittent fever, other symptoms, headache, chills, cough, sweating, myalgia, arthralgia, rash, rose spots, faint salmon-colored blanching, maculopapular rash over trunk and chest. Other intestinal manifestation and important signs, hepatosplenomegaly, epistaxis, bradycardia, complication, GI bleed, intestinal perforation, and neurologic. Lab diagnosis, type of specimen depend on duration. First week, blood, bone marrow culture, and duodenal aspirate. Second, third week, serum for Vidal test and urine and stool culture. Carrier stool and urine culture. Serum for detection of antibodies. 2 VI antigen sewage culture indirect way. Colonies of S. typhi, conventional BHI growth, automated back or back T alert. Backtick or back T alert. Subculture on Mekong agar, blood agar. On Mekong agar, non-lactose fermenting colonies, DCA, pale colonies with black center, XLD agar, red colonies with black center, Wilson Blair, black colonies. Identification, conventional culture smear, gram-negative bacilli, motility positive. Biochemicals, catalase positive, oxidase negative, indole, citrate urease negative, MR positive, and TSI shows K by A gas present except in S. typhi, H2S, S. typhi, small specks and paratyphi A absent, paratyphi B abundant. Automated by multitop or Vitek. Antibody detection 2 to 3 week of illness Vidal test. Either by slide or tube agglutination and result O antibodies, granular chalky clumps, H antibodies, cottony woolly clumps. Significant titer O more than 100, H more than 200. Hello students, let's study Vibrio cholerae. So Vibrio cholerae classification based on Gardner and Venkatraman. So Vibrio, they are divided into two groups, Vibrio cholerae and other Vibrio species. Then subgroups of Vibrio cholerae 01, 0139 and non-01, 0139. So that means they are 02 to more than 200. Then biotypes 01 is divided into classical and Eltor, and serotypes classical Eltor are divided into Ogawa, Inaba and Kojima. 01 subgroup agglutinated by O1 antisera, responsible for all pandemics and most of the epidemics of cholera. Non-agglutinable vibrios not agglutinated by O1 antiserum, initially thought to be non-pathogenic, non-cholera vibrio. O139 serogroup, O139 not agglutinable by any of the antisera available at that time, 01 to 0138. So it is called 0139 Bengal strain, spread rapidly along the coastal region of the Bay of Bengal. Non-01, 0139 subgroups, serogroups have occasional sporadic outbreaks of diarrhea and extraintestinal manifestations, but never epidemic cholera. So Vibrio cholera. Morphology curved gram-negative bacilli, actively motile by single polar flagellum, non-sporing, non-capsulated. Pathogenicity cholera, transmission, ingestion of contaminated water and food. Virulence factors cholera toxin, fragment A1, active fragment, adenyl cyclase, converts CAMP, increase in CAMP, accumulation of sodium chloride in intestinal lumen, water moves passively into bowel lumen and watery diarrhea. Loss of fluid and electrolytes, shock due to profound dehydration and acidosis due to loss of bicarbonate. Clinical manifestation, watery diarrhea, sudden onset of painless watery diarrhea, rice water stool, watery with mucus flakes and inoffensive odor. Vomiting may be present but fever usually absent. So according to weight loss, less than 5%, increased thirst, symptoms increased thirst at 5 to 10%, postural hypotension, weakness, tachycardia, decreased skin turgor. More than 10% water loss, symptoms, renal failure due to acute tubular necrosis and fluid loss result in oliguria, weak or absent pulses, sunken eyes, sunken fontanelles in infants, wrinkled skin, washerwoman-like appearance, somnolence and coma. Lab diagnosis, specimens, freshly collected watery stool, rectal swab, convalescent and carriers. Transport or holding media, Venkatraman Ramakrishna medium, alkaline salt transport medium, Carrie Blair medium, autoclaved seawater. So all these have their alkaline pH. Gram staining of mucus flakes of feces, short covered comma shaped gram negative rods arranged in parallel rows, called as fishing string appearance. Motility testing, hanging drop, darting motility, shooting star swarming, gnats motility. Culture, peptone water, uniform turbidity with surface pellicle, aerobic. Nutrient agar, translucent colonies, blood agar, hemodigestion. Enrichment media, alkaline peptone water, Mansour storcolate, therulite peptone water. Selective media, alkaline bile salt agar, Mansour gelatin, torcolate, trypticase, therulite agar, pH 8.5, translucent colonies with grayish black center. Mekong agar, late lactose fermenting colonies. TCBS agar, thiosulfate citrate bile salt as inhibitor. Sucrose, pH 8.6, yellow color colonies because of the sucrose fermentation. Identification, biochemical testing, biotyping. Catalase oxidase positive, indole positive, VP positive for LTOR and negative for classical. Citrate variable, urease negative, TSI, acid by acid gas absent, H2S absent. Nitric reduction test positive, cholera rate reaction positive. String test, colony mix with loop of 0.5% sodium deoxycholate. On a slide, string is formed. Salt tolerance test to differentiate from halophilic vibrio. Zero grouping by agglutination with Vibrio cholerae polyvalent O antisera. First, the colony is tested with O1 antisera. If found negative, then tested with O39 antisera. And then serotyping. So, no, 01 no, Vibrio cholerae can be no, of two types, classical and LTOR, and they are differentiated on basis of these investigations. So, beta hemolysis on sheep blood agar, classical negative, LTOR positive. Cheek erythrocyte agglutination, VP, is then CAMP, negative for classical, positive for LTOR. Polymyxin B, 15 international units, classical sensitive, LTOR resistant. Group 4, Phage susceptibility, classical susceptible, LTOR resistant. LTOR Phage 5 susceptible, classical resistant, LTOR susceptible. Cholera tox gene, CTX1, classical, and LTOR CTX2. Then serotypes, Ogawa antisera and Inaba antisera. So Ogawa antisera plus, Inaba minus, Ogawa minus, Inaba antisera plus, Hikojima, Ogawa and Inaba antisera both plus. Treatment of cholera, fluid replacement, most important, mild to moderate fluid loss, oral rehydration, ORS solution. Severe cases, intravenous fluid replacement with reverse lactate or normal saline. Antibiotics have a minor role as pathogen is toxin mediated. Drug of choice, macrolides, erythromycin, azithromycin, alternative doxy, ketra, ciprofloxacin. Prevention general measures, safe water, sanitary disposal of feces, proper food sanitation, prompt outbreak investigation and steps to reduce transmission, notification, health education, chemoprophylaxis, tetracycline, household contacts only during epidemics. Hello students, let's study Pseudomonas. In morphology, gram-negative bacilli, actively motile bipolar flagellum, Pseudomonas aeruginosa, green pigment, pyocyanin, bluish green, fluorescent greenish yellow, other pigments, pyoverdine, pyorubin, and pyomelanin. Classification, pyocene pigment present, Pseudomonas aeruginosa, pyocene pigment absent, Pseudomonas malai, Pseudomonas sulomolai. Pathogenicity, virulence factors, pigment production, inhibit other bacteria, diffusible toxins, exotoxin A, proteases, phospholipases, hemolysin, elastase, pyocyanin, mediate tissue injury. Exotoxin A, most important virulence factor for Pseudomonas aeruginosa. Clinical manifestation, nosocomial infection, suppurative otitis, infection of wound, eye, burn, urinary tract infection, diarrhea, meningitis, septicemia, ventilator-associated pneumonia, chronic respiratory tract infection, bacteremia leading to sepsis, septic shock, infective endocarditis, ear infection, eye infection, skin soft tissue infection. Laboratory diagnosis, specimen, pulse, wound swab, urine, sputum, blood, CSF, direct smear, gram-negative bacilli, culture, obligate aerobe, nutrient agar, large irregular colonies with metallic sheen with pigment production. Characteristics, sweet odor, alcohol-like fruity odor. Then blood agar, beta hemolytic gray colonies. Mekong agar, pale non-lactose fermenting colonies. Selective media, cetrimide agar. Then biochemical reactions, catalase positive, oxidase positive, indole MR, urease negative, citrate positive, TSI K by K, and then AST is done for drug sensitivity testing.
Hope you find this session useful for your understanding and for your exams. Thank you.